Sir?
Thank you very much for this opportunity to participate in the BRIC live course. And so I'm going to start off my topic by going through a case example. This is a 40-year-old Chinese male with a risk factor of smoking, and then he came in with a sudden onset of chest pain. As you can see from the ECG, there's a ST elevation here. There's ST elevations in the high lateral leads with reciprocal changes in the inferior leads. And this is the angiogram. You can see that this is a proximal LAD artery. There is actually a tendon narrowing, but this is not the culprit vessel. The culprit vessel is actually an occluded diagonal artery. So this artery is occluded here. So we go ahead and fix the diagonal artery. The question now is, what do we do with the proximal left anterior descending artery, which is still there, right here? And there's another one lesion there proximally. And when we do the right coronary artery, there is also another lesion there. So the question here in these patients with multivessel disease in a STEMI setting is, what do we do with it? Do we just treat the diagonal and leave the rest alone? Or can we go ahead and do a multivessel primary PCI for every of the remaining lesions? Or can we stage the PCI during the hospital stay of this patient? Or do we stage the PCI after the patient has been discharged? So we know that the background of this particular topic is that primary PCI was first performed by Peter Rantrop in 1978. We know that multivessel coronary artery disease occurs in about 30 to 65% of patients during a primary PCI for STEMI. And this is associated with worse outcomes compared with people with single vessel disease. And Jeffrey Hatzler actually was a pioneer of a multivessel PCI in patients with STEMI, but he actually at that time recommended an early staging of PCI, which was in the era of balloon angioplasty. We also know from the very early study in the Swiss tool that when somebody has Poseidon ischemia after AMI, it is associated with cardiac death and MACE and so forth and bad outcomes. And we also know that in patients with STEMI disease, they oftentimes have also concurrent multiple unstable plaques in the rest of the other coronary vasculature. And so in the primary PCI era where we now treat all our patients with STEMI, STEMI still have a high morbidity and mortality, and we all also know that complete revascularization is always better than a partial revascularization in improving clinical outcomes. The question to be answered here is really the impact of STEMI pathophysiology on the non-culprit vessel plaque, and how is the treatment of the non-culprit lesions able to alter the natural history of coronary disease after STEMI and result in a clinical benefit for the patient. Now, I think for the proponents of those who only do culprit-only PCI, the argument has always been that already this patient is a sick patient. Any form of ischemia and complications as a result of a non-infarct related artery PCI will be very poorly tolerated. And there's the potential for hemodynamic and electrophysiologic instability as a result of complications. Plus, the increased contrast can cause contrast-induced nephropathy, and oftentimes we may not have the time to know the patient's renal status. And it's always better to perform the second procedure on an elective basis and in the delayed fashion, because we are dealing with a STEMI milieu, and STEMI milieu can result in systemic vasoconstriction, endothelial dysfunction, and we oftentimes is unable to estimate the size of the non-infarct related artery very well, nor the lesion severity. And oftentimes optimal reperfusion of the infarct artery can occur, and you can have actually a very heavy thrombotic burden in this patient as well. The platelet activation, pro-thrombotic state, all increases the risk of a stent thrombosis. But the argument for people who want to do multivessel PCI at the same time is that AMI represents a generalized pathophysiological derangement of endothelial dysfunction, coagulation, and inflammation. So it has the potential to impair coronary perfusion beyond the culprit lesion distribution and destabilize plaques throughout the coronary vasculature. And so there's no time like the present. The patient factor, from a patient perspective, this is a captive audience, is already on antithrombotic, and why don't you go ahead and do the multivessel PCI? This will avoid a lost follow-up. From the clinical effect perspective, there's a potential for improved hemodynamics when you relieve the ischemia of the other artery stenosis. reduce ischemia, prevent reinfarction, and vessel preservation. From a system of care, there will be fewer procedures being done and perhaps leading to a decreased total cost of care. So when we look at the early data, and you look at the patients who have culprit lesion, which is marked by this orange bar here, versus patients who had a multivessel PCI done, actually multivessel PCI didn't seem as though there were more advantages compared to just culprit-only PCI. But this is really in a very early stage. When we look at some of the meta-analysis looking at long-term mortality, you find that actually there is a suggestion that the multivessel PCI is conferring a superior mortality benefit compared to a single vessel. And most of this benefit of a multivessel PCI occurs in a staged fashion rather than a index procedure. That means you can either do it stage in hospital or stage as an elective outpatient. But all of the studies in this particular meta-analysis were based on registry rather than randomized control trial. I think the first three randomized control trials that we all know we are very familiar with regard to culprit lesion versus multivessel PCI and patient STEMI are the primary, culprit, as well as the pre-multi trial. And when we look at the primary endpoint, which are somewhat different among these three different trials, but they all give the same message, that the culprit multivessel PCI is better than the conservative approach where you only treat strictly the culprit lesions and do nothing to the rest of the other coronary vessel. There was all a consistent finding of a reduction in terms of ischemic endpoints, both hard as well as soft. It's hard endpoint like death and myocardial infarction, and soft endpoint like a reduction in ischemia revascularization. So when we look at culprit trials specifically, looking at a composite at 1 year, there was a significant reduction of total mortality regarding reinfarction, heart failure, and ischemia-driven revascularization in the complete revascularization group. But when you follow up these patients up to 5 years, you find that there is now a significant reduction of hard clinical endpoints of death and myocardial infarction. And majority of this benefit were observed in the early part of the procedure, and then is sustained throughout the entire 5 years. So culprit trial is the first trial to show a reduction in the hard clinical endpoints of death and myocardial infarction over a long-term follow-up. I want to highlight this particular trial called the DANAMI pre-multi trial, because this trial actually was quite different from the rest. It uses FFR, which is the physiologic guidance, in determining whether a patient needs to go for a repeat revas or revascularization procedure. And the superiority of the complete revascularization in this trial was driven by a 70% reduction in repeat revascularization, not in the hard clinical endpoint, but just a reduction in revascularization. And using FFR as a mode of determining whether to intervene or not was also carried out in the next trial, which is called the Compare Acute trial. And again, on the Compare Acute trial, the benefit in terms of reduction in MACI was driven by a reduction in the need for revascularization. But those using FFR assessment of non-culprit coronary artery stenosis and AMI, is it really that accurate? We know that assessment of FFR in a culprit vessel is really not so predictable and not so accurate in the setting of AMI. But when you assess a non-culprit coronary artery during STEMI at the baseline and then compare it in a month's time in this particular study, you will find that actually the FFR remains largely the same. It did not change between the acute and the follow-up in the non-infarct related arteries, suggesting that we can actually use FFR to measure the non-infarct related artery lesion. Finally, the most important trial that we all have to understand is really the complete trial. Complete trial is different because it is the biggest of all the randomized control trials, 4,000 patients randomized to either culprit versus multivessel PCI. And there are two co-primary outcomes here. One is the hard clinical endpoint of death, myocardial infarction, and the other one included ischemia-driven revascularization. And here, I want to highlight to you that in the complete trial, it shows there is a reduction in hard clinical endpoints, just like the culprit trial at 5 years of follow-up. And this is also a 5 years follow-up in the complete study. What is also important in the complete trial, it tells me that when you do a multivessel PCI, whether it is during the hospitalization or whether you let the patient go home and then do the procedure within 45 days of index procedure, the benefit was still consistently in favor of a multivessel PCI. So it doesn't mean that you actually have to do your procedure right away or during the index hospitalization. You can always go home first and then come back and do an elective procedure. So if you look at this 5 randomized control trial, you find that there was actually some differences and also some similarity, but suffice to say, some of them uses angiographic inclusion criteria, some uses FFR as an inclusion criteria. So if I were to combine all this latest randomized control trial into this meta-analysis, we can now clearly see that the multivessel PCI in the patient with STEMI lowers the risk for reinfarction, lowers the cardiovascular mortality, and lower repeat revascularization, but no difference in major bleeding, stroke, and contrast-induced nephropathy. So there's advantage in terms of doing multivessel PCI. So should we just rely on FFR, or should we just rely also on angiogram as a guide in terms of non-culprit lesion? When you look again this meta-analysis comparing FFR guided versus angiography guided for non-culprit lesion, it would appear that angiographic actually confers benefit more than FFR. So what is going on here? Maybe FFR predicts only flow severity. It doesn't tell you about the lesion's complexity as well as its vulnerability. Maybe an angiographic follow-up might be more relevant in this sort of a setting. And now we have come to realize that there are this trifecta sort of lesions that we should be looking out for in terms of predicting a patient's likelihood of developing acute coronary event after his STEMI. And this is the triple L lesion that we talk about here. A large plaque, when you have a very large stenosis, a large plaque on IVUS or any of the imaging, it is a predictor. When you have a plaque that is rich in lipid core, that is also a predictor. And when you have a lumen area that is stenosis of less than 4 square millimeter, that is also a predictor. When you all three are together, this increases a patient's likelihood of a cardiovascular event during a course of follow-up. And we also know from the recent TCT Connect that it is possible to intervene in such vulnerable plaque using a bioresorbable scaffold here called the Absorb Prospect trial, where after intervening in this so-called vulnerable plaque, there was a slightly higher minimal lumen area in those intervened vessels, but this study is really not powered for a clinical event or a safety event. So we now have to wait for more trials like a prime time to tell us whether FFR is better than angiography guided, whether it should do it inpatient or whether it should do it as an outpatient, and whether it should do infarct-related artery only or multivessel disease. Certainly more trials and findings needed. So let's look at what are the guidelines saying. In 2013, ACC/AHA suggests that PCI should not be performed in a non-infarct-related artery at the time of primary PCI. It was a class 3 recommendation. Then in the latest 2015 focus update, it was elevated to a class 2B. So evidence not in favor, but it's better than the class 3. But when we look at the ESC recommendations in 2018 on myocardial revascularization, it gives a 2A recommendations to a routine revascularization of non-infarct related artery lesions in the patient with STEMI. But none of this actually refers to a hemodynamically significant lesion which is causing impairment of blood flow. Clearly, when you see another artery which is the non-culprit lesions, having very tight lesions and having thrombus and is impairing flow with great TIMI 1 or 2 flow, you should intervene. It doesn't fall within the guidelines of this recommendation. So what did I do during the procedure? So this was the RCA. So I did the FFR at the time before I finished up the procedure. The FFR measure was 0.89. So this is hemodynamically not significant. I measured the LAD before I stopped the procedure. The LAD FFR was 0.76. So I actually let the patient go home first after treating the diagonal vessel. And then I brought him back 2 weeks later and I repeated FFR. The FFR was 0.84 this time around. It was pretty close to the 0.89 done 2 weeks ago. When I repeated the LAD FFR, it was 0.76, exactly the same as before. Then I proceed to fix the LAD lesions with implantation of stents, and the FFR improved to 0.89. So in conclusion, I think the perspective here is that it's really not a question of when whether we should be doing a multivessel PCI in patients with multivessel coronary artery disease, but really when should we be doing it is the real question. And certainly a conservative management of patients with residual multivessel disease is just not good enough. However, there's still many questions that need to be answered. Whether we should do it immediate or stage PCI in multivessel disease, this has not been answered in any of the clinical trial. Whether in hospital is better than beyond 30 days, again, we don't know. How should we be selecting the lesion? Do we take the complexity of the lesions into account, such as those with CTO or left main and so forth? Did we stratify for evidence of ischemia? Is it a small area of ischemia, large area of ischemia, and so forth? And what about the patient-specific decisions, such as whether his comorbidities such as stroke or chronic renal impairment, and so forth? So I think the complete revascularization should not be routinely performed ad hoc during a STEMI setting, but based on individual and careful patient and lesion assessment. Thank you very much for your attention.
Thank you, Professor Tan Hui Chim. We have some of the renowned interventionists among us, like Professor Madam Sufia Rahman. She's a professor of emeritus, and she was actually the founder of intervention cardiologies in Bangladesh and ex-director of NICVD. May I call Madam to chair the session, and we have also with us Professor Dr. Abdullah Shafi Mazumdar, ex-director NICVD among us. I also call Mujumdar sir to chair the session. And we have also Professor Dr. Chaudhry Meshkar Ahmed sir with us as a panel of experts. So, and we have some international speakers among us, like Professor Mansoor Salam. So he's a professor of cardiology, Al-Azhar University, Cairo, Egypt. And also we have Young Cheol Kim. He's an assistant professor in Yongin Surveillance Hospital, Yonsei University College of Medicine. So I welcome you all in our scientific session. And we have Professor Khandagar Shohid Hussain and Dr. Nur Alam, and also Dr. Nur Alam as an associate professor, as a moderator. So please let's moderate the session from now on. And now the floor is open for discussion.
Hello, Professor Chim. How are you?
Hi. Oh, how are you, sir?
Yeah. Yeah. I was a bit late to join, so I was at the end of your presentation. And as usual, it was a very elaborate presentation, I think. And you make some specific points at the end, which I noticed you made at the end of your presentation. Which one should be the staged? You prefer to be the staged PCI in the cases of the STEMI. Is it so?
Yes. I do stage PCI unless there's clearly ischemia causing lesions that I can see in the other vascular, which is non-culprit.
Okay. Thank you. Thank you for again seeing you.
Very nice to see you.
Hello, Jim. Nice to see you again.
Hi.
And as usual, your presentations, I also joined late because I was called to proxy somebody. So anyway, it was a nice presentation, no doubt about it, as usual. And hope you are keeping well in this pandemic situation. But you are busy, I know. This presentation, I'm sure juniors will benefit. You have really highlighted the points which we need to highlight. And I'm sure in future you will be with us because you are part of our Bangladeshi cardiologists, and you have got a lot of friends and patients both. So I hope you will have a good life, and wish you good luck as well. Thank you. It was an excellent presentation. Thank you.
And Abad Dekha Hobe.
Abad Dekha Hobe. Inshallah. You have to learn the Inshallah also. Shafi Mujumdar, Assalamu alaikum.
Alaikum assalam, madam. Yeah.
অনেকদিন পরে দেখা হইলো।
Ji, madam.
Okay, what is next? Is there shall we go? Anybody else want to discuss anything? Any questions from anybody?
Can I ask one question to Chan Huichin? Is there?
Yes, he's there. Yeah.
How are you? I am Professor Amar from NICBD. My question is that at the time of inferior MI STEMI, RCT is 100% occluded naturally, but in chest staging of the opposite side shows there is a hazy lesion more significant, more than 90% lesion in main LAD, critical, very critical with haziness. What will be my experience is that if one patient I left in the primary at the setting of primary PCI at night, it developed and they doing another primary PCI in the next morning, and another patient I lost due to cardiac. What is your experience like this type of dilemma in both sides?
So it's obviously a very difficult judgment call. But in general, if the lesion, which is very tight, but it's not causing impairment of blood flow, I would actually give the patients antibiotic therapy to sort of cool him down first, at least for 1 or 2 days before I start intervening. And that would be my strategy. But if there's clear flow impairment and I can see a clot within the artery, then this is where I will intervene in that particular non-culprit vessel. But it's always going to be a judgment call.
Thank you.
Yeah, Dr. Tan, can I ask a question?
Hello.
Yeah, Dr. Tan. I'm Professor Khan. I'm telling that you in your complete trial or Tri-Multi or DANAMI 3, and in these trials also there is one subset of the patients which are coming for primary PCI with hemodynamic compromise, cardiogenic shock. That cases complete revascularization. You know that there is a dilemma there. Still, this dilemma prevails in the intervention world. What's actually, because in this sort of cardiogenic shock patients, actually complete revascularization is better. But from PCI perspective, at that moment, to do the ad hoc multivessel PCI is also a big dilemma for interventional cardiology. So what's your feeling there?
Well, actually, we have the Culprit shock trial to guide us on this particular aspect. And Culprit shock tells us that in the patient with cardiogenic shock from AMI, we should really just be doing the culprit lesions. Intervening in the other arteries did not confer any benefit. In fact, there's actually a worse renal impairment in the group that had multivessel PCI. So I think Culprit trial shock tell us that actually there's no benefit.
Yeah, but in case of cardiogenic shock patients.
Yeah, so exactly. There was a cardiogenic shock trial. So in the shock patient, just do culprit lesions.
Okay.
Dr. Nur Alam, please moderate the session.
Sabina Hashem, can you hear me?
Yes. Please moderate the section. We are running short of time. In fact, I think we should go to the next speaker.
Okay. Learned honorable chairpersons and panelists and the speakers, Dr. Nur Alam here, going to moderate along with Professor Khandakar Shohid Hossain, who will moderate next of the session. Before going to next speaker, I would like to add one point. Professor Saidul Rahman asked a question regarding the shock patient in primary PCI. What will be their strategy? Should we go for multivessel PCI or not? In 2000, as Dr. Chem already shown that in 2018 ESC guideline, they do not recommend to non-culprit vessel PCI in a shock patient. But still, as Professor Saidur Rahman mentioned, it is a from the interventional perspective, it is a big question whether we perform the non-culprit vessel PCI in a shock patient in a primary PCI